morning, guys. I think I wanted to record this video, just hopefully being able to help with the ventilator checkoff. So I'm going to go and just proceed reviewing the traditional checkoff, what is in calendar, what is expected, how you get just a visual for the waveforms that you're expected to know during the time of checkoff. So you know that for the most part, at the initial setting, just connecting the filter, the breathing circuit, and testing the lung to proper location for the ventilator is expected. You're supposed to complete either the EST or the SST, depending on the ventilator. And you may initially be asked to set up the ventilator on volume as its control. So with volume limited, please make sure that you select the right parameters for tidal volume, for frequency, for FiO2. You may be asked to, just to conserve oxygen, to turn it down to 21%. PEEP, it is extremely important that you remember something. While you may be focused on setting the IE ratio to be just the ideal 1 to 2, the fact is that depending on the frequency you use, you may end up with an inspiratory time that is not adequate for the ICU. So you may end up with an inspiratory time of 1.4, saying that yes, it is 1 to 2. But the practical point to take is that in the ICU, the adult is going to be around 1 to 1.2 seconds. Rarely you will see 1.5 or 1.6 or 1.7 at the expense of just having a low rate, like 12, where you have 5 seconds, and then you're going to be using just a huge amount of inspiratory time. So keep in mind, while it is important, the I ratio to be 1 to 2 or better, it is ideal to concentrate on the inspiratory time. Remember that during expiratory time, that's where the patient is going to initiate some spontaneous breaths. So when you're asked about setting your alarms, keep in mind that while there is no really a good set of rules, no mechanical ventilator company recommends alarms, and it's going to be very hard to find just a true data on where they need to be set. While you want to avoid just alarm nuisance, you want to make sure that at least 50% for minute ventilation, respiratory rate, and so forth, and typically no more than 10 to 15 centimeters above the peak pressure. The low minute volume alarm, once you set up the patient, honestly, it should be as close as what you see on the minute volume, because otherwise you will encounter a leak. And I would like to know how soon it is. So let me give you an example. If after I set up my ventilator and I read that the minute volume is 4.8, I'm already accounting for leaks, maybe around the tube, around the circuit, the humidifier, and so forth. So I could be just selecting a minute ventilation low alarm to be like 4.5. Why? Because that's the assumption that I have, that I'm already accounting for leaks. The high minute volume alarm will change once the patient starts breathing. So that could be a moving target, but not so much for the low minute volume, unless I reduce the mandatory rate. When you're asked about trigger, it is extremely crucial to remember that sensitivity is how easy you make the ventilator respond to a patient's effort. So you can have a assisted breath. So a patient trigger breath will only happen when you, as the operator, set the adequate sensitivity. And you know by heart that the adequate sensitivity is what? The highest sensitivity that you can set for the patient, or for the ventilator, without going into auto trigger. When I mean high sensitivity, I don't mean the highest number, completely the opposite. When you are on flow trigger, you want to make the lower number possible without causing auto trigger. If you set, let's say, your bias flow at 3 versus 5, in which case it's going to be easier for the patient. When the patient will have to just work with 3 versus 5. So the lower the number on the bias flow for the flow sensitivity, the easier it's going to be for the patient. Completely opposite for the negative pressure, or the pressure trigger. The higher the number it goes in this case. So if you go from -1 to -2, so -2 will cause the patient to work harder because now instead of just pulling down -1, the patient will have to create a pull of -2 or -3 or -4 to generate a patient trigger breath. So the higher the negative pressure number it is, the harder they will have to pull. The higher the bias flow is, or the flow trigger number is, the harder they would have to pull. While you may be able to define auto trigger just by, again, just when you memorize the definition, it's very critical that you recognize how it is displayed on the ventilator. So auto trigger, just by definition, is when the patient is not generating the breath. So you don't have a patient trigger breath, and all of a sudden you see a very rapid respiratory rate. One of the things that would cause that could be because the sensitivity is inadequately set. So it is extremely sensitive. The ventilator is very sensitive to any type of movement that could cause a false trigger. Well, the other one would be a leak. A leak is commonly causing auto trigger. While it is very tempting to change the sensitivity setting because then you may want to, let's say, increase the number of sensitivity, so you make the ventilator less sensitive to patient effort. That will be just a temporary solution to this. You need to find out exactly what is causing the auto trigger. So if it is a leak, there's nothing you can do about it because let's say you have a bronchopleural fistula as a respiratory therapist, you are not going to be able to do anything about it. You may, in this case, decrease or make the ventilator less sensitive by going up in the number until they found a good solution. Otherwise, the ventilator is going to be auto trigger. Remember that the ventilator will be just telling you assisted or spontaneous. So it will change and it will be trying to fool you into believing that there is a spontaneous breath. But the key is, how do you recognize that this is not a patient trigger breath? So when you're looking at the ventilator waveforms, I would invite you to look at the pressure versus time. You can also look at the flow versus time, but look at the pressure versus time. You have learned just from the mechanical ventilation course that if there's no presence of a negative deflection prior to the breath, it is quite possible the patient is not generating the breath. So not only you look at the patient is not making an effort, but also, by the way, it seems like the ventilator is reading all the spontaneous breath, but in fact, you don't see a negative deflection at the initiation of the breath. That indicates it is a patient trigger breath. So when somebody's asking, so how do you know if the patient is not breathing, even though the ventilator is saying this, is just the absence of that negative dip or the negative deflection is indicated when you have auto trigger. So not only fast rate, but the fact that when you analyze the pressure tracing for those breaths, there is absence of the negative deflection that is very characteristic of the patient-initiated breath. Patients' demand for flow may decrease or increase. In most cases, when patients have a difficult time breathing, they will actually require a higher flow. So you need to know that, of course, when you provide, let's say, for example, you calculated that based on ideal body weight, you needed a 420 mLs. It's going to be delivered probably in 1 second. What if the patient's demand for flow is much higher? So if you increase the flow, what is going to happen if the setting for inspiratory time depends on the flow setting, you turn the flow up or down to modify the I time. In this particular case, you have to realize that you are not changing the time of volume. You're still delivering 420, but with a faster rate, that will result in what? Decreased in the I time. Sometimes you may have to increase the flow also to shorten the I time, and then you will have a longer expiratory time for patients with airway obstruction. So instead of just going right or left, you need to decide, okay, what am I going to do if I need to lengthen the inspiratory time? Well, if I have more time to deliver the same type of volume, I have a longer I time. But if I need to just expedite the flow or the delivery of that type of volume in a shorter period of time, what I do is I increase the flow. You probably realize that when you're told to set up a patient with really just altered mental status, nothing is going on, you don't have the presence of massive atelectasis, or you don't have the presence of ARDS, And you get this call about, remember this morning when we had this patient with a peak pressure of 25 and now it reached 40? What I want you to be thinking is that there are only two reasons, possible reasons or categories of reasons that could explain why the peak pressure is going up. One of them, one of them is going to be decreased lung compliance. The other one is increased raw or increased airway resistance. So when you walk to the bedside, you ought to be thinking, how do I determine also visually what is going on? What do I have to do? And of course, what I need to be thinking is, in order for me to split that peak pressure in what it is resistance or what it is compliance, I need to calculate or I need to measure the plateau pressure. And of course, you know that plateau pressure is going to be obtained by just pushing the inspiratory hold. So when you do apply the inspiratory hold, depending on the ventilator, it will just show a different color. But the key is to recognize that pause. So if there is a huge separation, as you have seen before, if there is a huge gradient between the peak pressure and the plateau pressure, it is airway resistance. So the patient that may require an inhaled corticosteroid, a bronchodilator, or to be suctioned. While on the other hand, when the plateau pressure almost matches or is very close to the peak pressure, that indicates that below this point is alveolar compliance. So it is saying that when the P plat almost matches your peak, is indicative of alveolar compliance. So for those particular patients, you have to think of recruitment maneuvers that may include just an alveolar recruitment maneuver or just going up on the peak. So I mentioned that one of the most significant causes of auto trigger is a leak, because the ventilator in sense senses that maybe the patient is pulling so hard or is making an effort that is drawing from this bias flow, and the ventilator, as a missed signal, recognizes this as a patient's effort, and it just causes a trigger. But in reality, when you leak, is mLs. You measure the leak not only in percent, just compare the set tidal volume versus the Excel tidal volume, but also what you want to determine is that how many mLs am I leaking? If I have a set tidal volume of 420, am I getting those? I'm getting back those 420. So that means that if I leak volume, I need to be thinking is, how do I recognize this on waveforms? So there will be three different waveforms that will display the leak. One, the volume versus time. The other one is going to be the flow volume loop, and the other one is going to be the pressure volume loop. In those three instances, there will be a gap between the inhaled and the exhaled. Depending on the ventilator, you can also tell that this gap is indicated by a straight line that could cause, on a volume versus time, a check mark. But this the size or the magnitude that you can look at the scale of this gap is going to be the same on a flow volume loop and also on the pressure volume loop. When you are setting your patients, when you have been asked to switch from volume limited to pressure limited, the key is, what is the target tidal volume? So if the target tidal volume in this particular example is 420, guess what you have to do quickly? You need to move that inspiratory pressure and titrate up until you see the target tidal volume. So that's why it is so important. If somebody is going to ask you to start a patient on pressure control, what you have to start thinking is, what is my target tidal volume, so I can just go ahead and just apply that pressure gradient. So remember, the driving pressure in this case will be the difference between my PEEP and my peak pressure. That's going to be what is driving my tidal volume. While the pressure that I reach doesn't change once I set, let's say, 25 centimeters water, how fast I can deliver or I can get to the pressure could make a difference. So in that particular case, what I need to know about FAB or ramp is, how fast do I want to reach that pressure, depending on the patient needs or hunger for that pressure that I reach. So it is critical to also understand that the pressure that I reach, which is supposed to be square at this point, and remember, square on the pressure versus time indicates a pressure mode. As I mentioned on checkoffs, when you sense when you do survey your ventilator patients, you can say by just looking at the pressure versus time from a distance, how many patients I have on volume, how many patients I have in pressure, by looking at the pressure versus time. If it's square, you may not be able to recognize that as a PRVC, APRV, PCAC, PCA, SIMV, but you know for sure that the patient is on a pressure limited mode. So how fast it is, it will really depend on patient needs for that speed that you need to achieve to deliver that pressure. Remember, something that you don't want to see is that overshoot of the pressure. So if the pressure is going way too fast, you need to slow it down or just to change the ramp until those dog's ears at the beginning of the breath on top of the pressure just simply just go away. If you have selected SIMV in this particular case, either with volume or pressure, you need to be thinking of the fact that SIMV is a combination mode. So that means you have a set of mandatory breaths. In this particular case, let's say I set the rate at 15. So I know for sure that no matter what the patient does, even if the patient is in coma, I'm going to get 15 breaths. So every 4 seconds, I'm going to get a breath. But somewhere in between these breaths, particularly at the expense of the expiratory time that I have, it may be a 1-to-3 ratio. So during that expiratory ratio, what I'm going to do is I'm going to allow the patient to take spontaneous breaths. So if those are going to be spontaneous breaths, they are not going to be mandatory. So they may be very small. So in order for me to target how I'm going to help those spontaneous breaths, that's the purpose of pressure support. So I think it's very clear that when you have less than 4 mLs of the exhaled tidal volume on those spontaneous breaths. So remember, you see this tiny breath, just look at the tidal volume exhale. If that is less than 4 mLs per kilogram, you need to up that. While there may be different opinions, let's say my target is to be about maybe 5, no more than 6 mLs per kilogram, because I don't really want to match what they're getting mandatory. Might as well just put them on assist control. So if the target is about 5 mLs per kilogram, I think I would be happy because that's the way I'm helping the patient to boost their spontaneous breaths to get at least 5 mLs per kilogram. It should be very obvious at this point with the first checkoff is that you need to understand what happens on volume ventilation when compliance decreases or raw increases. On volume ventilation, when the volume is preset, the only variable that is going to change is pressure. So I'm protecting with volume limited the amount of tidal volume, but I'm going to be allowing, in a sense, because I have no control over the pressure. So if situation in the lung or airways goes bad, I need to assume that it's going to take more pressure for this volume to be delivered. Now let's switch to pressure. Pressure is preset. So really nothing is going to occur if things change in the airway or lung compliance. But I need to remember the fact that if my preset pressure is not going to change, my volume is going to change. If things are good, if things are better, for the same amount of pressure, I'm going to get higher volume. But if for the same amount of pressure, I have a worsening compliance or increased resistance, I'm going to get less volume for the same amount of pressure. Depending on the ventilator, you will see that is a VC plus or is that a PRVC. So let me just stick with the pressure regulated volume control. It is deceiving because it ends with VC, which is volume control, but it's really not a volume limited mode. It's a volume targeted mode. What is really in domain, if I can say that, is a pressure. Pressure is really what is regulated. And also the key is once you switch, if you don't remember exactly what type of mode it is, if it is volume or pressure, look at the pressure versus time. You'll be surprised that you remember that the square means a pressure control mode. So it's a pressure control mode with a volume targeted mechanism. You also have to know that when things go bad on PRVC, the first thing that you're going to see is that volume goes down. As a consequence, the algorithm will allow this ventilator to, again, creep up on the pressure to regain that volume. And if the volume goes up, then in order to protect against barotrauma, now the pressure will come down, so the volume is really just staying within target levels. There's a significant variance between what is the flea flow sensitivity. You know for a fact, of course, that is going to be just applied to these pressure-supported breaths or pressure breaths, where you determine exactly how soon you want to finish inspiration. So it is ideal for patients who have airway obstruction because you want to set the E sensitivity at a percent that is not very low, because that means that you will have to decline flow all the way. And as long as you have flow, you have inspiratory time. You're taking away from exhalation. So the sooner you shorten that inspiratory time, or you set your flow to end and flow into exhalation, or just to transition into exhalation, the exhalation valve will open sooner, so you allow more time for exhalation to happen. Ideal for patients with airway obstruction. So speaking of patients with airway obstruction, there is a greater chance for these patients to trap gas. So gas trapping is a situation that you may encounter. Well, there may be different waveforms, particularly the flow volume loop, that you can determine. Also, the key feature is that in most cases when you go to the ICU, there are the scalars that are going to be displayed, not so much the loops. It takes actually a while for clinicians to switch to loops. But in front of the scalars, what you want to look at is flow. And in the particular case of flow, what you want to be looking for is the inadequacy or the inability of the flow tracing, the expiratory flow tracing, to go back to baseline, and it creates a gap before the next breath occurs. That is the presence of gas trapping. The next step is, yes, you can say, well, I'm going to slow down the respiratory rate. I'm going to just change the I ratio to allow more time for these patients to exhale. What you need to also be aware is how much auto PEEP this gas trapping is associated with. What is the unit for auto PEEP? The unit for auto PEEP is centimeters of water. It's not liters per minute. So what you may detect gas trapping, what you need to confirm is the presence of auto PEEP upstairs on the pressure versus time. And for that, you have the expiratory hold. The key is, yes, you may memorize that that's exactly what you have to do, but the key is, how do you recognize that you have auto PEEP? If you have no auto PEEP, once you create the pause, the flat portion of that will remain exactly the same, indicating that there's no changing PEEP. The circuit PEEP is the same as the intrinsic PEEP, so no PEEP, no intrinsic PEEP. But once you apply the pause, if there's a bump, that bump and the magnitude that you can actually scale indicates the amount of inadvertent or intrinsic PEEP. That is going to be important because not every single patient with the same degree of gas trapping will end up with the same degree of auto PEEP. And this too will be associated with issues with trigger asynchrony. So that's why it's important to recognize how much auto PEEP you have. Depending on where you work, you may be invited to set up bi-level or APRB. So few key aspects when you realize that this is a mode that you are not going to see that often. You may be surprised by working maybe in a PQ or even in an EQ, because there's now more abundant literature that speaks of the use of APRB in the neonatal population. So a few things that you have to keep in mind before you arrive to the bedside. So one, this is used typically for very strong, very restricted disorders that are associated with very severe hypoxemia. So ARDS patients, maybe RDS patients. The second thing that you have to keep in mind is that when you get to the ventilator, you need to be thinking that I need to see inverse I ratio. While it varies, it could be typically between 3:1, 4:1 to start with. And the other aspect that you need to have in mind is that you need to be able to generate something that you hate seeing in different modes, which is gas trapping. APRB, at this point, the evidence is very clear that unless you are allowing yourself to see gas trapping, APRB is not properly set. Trust me, you can see inverse I ratios without gas trapping because the T low is inappropriately long. That doesn't mean that you don't have the inverse ratio, but if you don't generate enough gas trapping, you are de-recruiting the lung. So when you arrive to the ventilator, you need to keep in mind selecting a rate. Let's say in my case, I just try to go for 12 to 15. If you go for a 20, so what is the difference between 20 and 15? That you're dumping, you're creating a dump of CO2 much more often. So only on those patients where you need a higher rate to actually eliminate more CO2, that's when you have to do that. Otherwise, I take advantage of the slower rate that allows me to have a longer inspiratory time. And I better see square pattern on the pressure versus time that is very long and a little time for the T-low. How do I titrate the T-low? Versus thinking so much or just being worried about how long the inspiratory time is going to be. Trust me, when you have 3 to 1 or 4 to 1 is already long. But the T-low is going to be what I'm going to be looking at is once I dial the T-low, I'm going to be looking at the flow tracing. Because the flow tracing is going to indicate to me if the expiratory tracing goes back or not to baseline. If it goes back to the baseline, the T-low is too long. I'm allowing, again, the exhalation of gas to be so long. And the purpose of APRB is to actually just take advantage of the prolonged inspiratory time, but I'm not going to allow you to de-recruit. So I need to shorten that so I can start generating air trapping. How much gas trapping? If you keep in mind that Dr. Habashi has recommended between 50 and 75%, stick with 50% just for now. Don't be too aggressive. But you need to make sure that that elbow on the expiratory tracing is at 50%. So how do I know 50%? Just stop the screen, freeze the screen, move your cursor to the lowest point of the peak flow on the expiratory. So this is baseline. Just choose the lowest point of that graphic. That will become, let's say, 60 liters per minute, 80 liters per minute. That becomes your 100%. So that means that on your way back, you don't want to reach baseline because that is zero gas trapping. What you want to do is you want to create this elbow at 50%. If I have 80 liters per minute, where do you think when I move my cursor to this point, where does it need to be? 40 liters per minute. That's exactly where I indicate that this is adequate. In terms of the PI, no worries. Many institutions do use the plateau pressure, or just you can use, as you said, any pressure mode. Just titrate until you get your Title 1. There are so many ideas about pressure support. My preference is not pressure support. It could be associated with very high transformatory pressures on the PI. If you don't set the patient too high or too much, the patients are able to generate their own spontaneous breath and they're able to, again, dump enough CO2. P-low, depending on the institution you work in the protocol, what I learned from Dr. Habashi, just P-low of 0, because then P-low is not the same as PEEP, so there shouldn't be any need for this P-low to be higher because you're already generating enough gas trapping and auto PEEP to be able to benefit from just the prevention of airway collapse. So I'm hoping that this review was useful to everyone. Just don't forget, just keep studying, keep practicing, and whenever you have a question, hit the lab and just make sure that you see what you read. If not, it's going to be a matter of just now memorizing things without making sense.